Welcome, everyone, to this virtual Boca Patient and Family Seminar. This was the first virtual seminar that we did a year ago. This is the anniversary of what has been a really horrific pandemic year. And so we're hoping that this will be an omen that we're maybe going to move out of this pandemic and be able to start having some live at some point during 2021. But to start us off, Susie would just like to welcome everyone, even although it's a virtual event. So, Susie.
Hello, everybody. I wish this wasn't a virtual event and that we were all together, but I'm sure that that will come soon again, and I'll look forward to seeing you all in person. So what I really think is amazing is how much we've all been able to get done, even during this pandemic. And for all of you all across the country who are working with the support groups, I just have to applaud you. It's got to be really hard, and it's a whole new way of interacting, but you're doing a stellar job, and I'm very, very proud of you. And I'm so anxious, though, to get back and see you all together.
All right. So thank you, Susie. I think everyone echoes those thoughts. But for today, we want to do the best that we can and allow patients to ask their questions, which are already now flowing into the chat box here. We have now 40 questions that have come in. So let's move forward here, Amira. So we're obviously very pleased to thank our sponsors, the Binding Site, Bluebird Bio, Bristol Myers Squibb, Genentech, Janssen, Oncopeptides, Karyopharm, and Sanofi Genzyme. And obviously, we're especially pleased that we have a stellar faculty today. So thanks to all of you for setting aside time on this Saturday morning to join us here. Dr. Brenner from right there in Florida, Paul Richardson from the Dana-Farber, Rafat Abonour from Indianapolis, Donna, oh, I'm so sorry with your surname, Catamero, I'm so sorry. My apologies, and Yelak, who was really excellent in reminding us that this was Saturday. So we really welcome Yelak to keep us straight here. Next, just to give you an overview of the agenda, there will be an open Ask the Expert session with myself and Dr. Brenner, although our other panelists will be available during that session also. Then I will give an introductory presentation about some basics of myeloma and a little bit about COVID-19. And then Donna Catamero, an important member of our nurse leadership board at the IMF, will talk about supportive care in a time of COVID-19. After that, there will be a break, and then this will be followed by presentations by Dr. Rafat Abonour and Dr. Paul Richardson. And of course, Yelak will remind us about what it means to be a myeloma patient and how to really work well in this current environment. And we'll have a closing Q&A session. So let's move forward, and we'll start with the Ask the Expert session with Dr. Warren Brenner from Boca Raton, who's actually wearing his white coat because he's on call this weekend. So let's start, Warren, with the first questions. We have a lot of questions about COVID-19. The first question that came in was from Carol Tucker, who said that she had a specific question about the COVID-19 vaccine. She had a stem cell transplant in the middle of last year, middle of 2020. However, she was diagnosed with COVID in December of 2020, so 2020 last year. She received treatment with monoclonal antibody therapy and has actually done extremely well. And so her question now is, she is 3 months out, and she's asking, should she just go ahead and get the COVID vaccine now, or maybe she should wait until 6 months out? So what do you think, Warren, about the timing of vaccination?
Thank you for inviting me, Brian. So thanks for that question, Carol. I think that's an important question that we're dealing with a lot these days. So our general recommendation would be to go ahead and be vaccinated roughly 3 months after you were infected, as long as there's no contraindication to you getting the vaccine. I presume you may be on some maintenance therapy, and if you're on something such as lenalidomide, that's not a contraindication to getting the vaccine. From a timing perspective, if you did it on your week of therapy, that would be very reasonable. But there doesn't look like there's any issue for patients on maintenance therapy getting the vaccine. So we would recommend that you go ahead and get that vaccine roughly 3 months from the time of your infection.
The earlier questions. Thank you so much, Warren. And so I'm trying to scroll down to the, here we go, to the earlier questions. Amira's going to do that for me. But one other question, just linked to what you were just saying, Warren. A patient was asking if they're on Revlimid maintenance, is it okay to get the vaccine? And asking actually if it would be good to get it on the week off of the maintenance. So how are you handling the vaccination during the maintenance?
If patients on lenalidomide maintenance without dexamethasone, we would go ahead and recommend getting the vaccination. It could be done on the week off, but I don't think we have any specific evidence that it would be wrong to get it well on lenalidomide. But I think it makes sense to get it on the week off, and then when you're due to have your second vaccination, if you're getting the 2-shot vaccination from either Pfizer or the other company, then I think trying to time it on your week off would make sense. But I don't think we have any specific data that it would be wrong to get it while you're still on lenalidomide maintenance, as long as there's no evidence of neutropenia.
Absolutely, absolutely. I think that I know it's very, very frustrating for patients because right now we actually just don't have any data. And so I use the formula of common sense. You know, if right. You can take the vaccine when you're on your week off, that's probably a better idea. Yes, and also that applies to other therapies. I mean, it's probably not good to take a dose of Darzalex, for example, on the same day as the vaccination. So just using some good common sense about the timing of the vaccine. We have another question, which is actually a common question. A patient wants to know, after having had the second dose of the Pfizer vaccine, her doctor has recommended that the antibody response be checked 1 to 2 weeks later. But this patient had learned that apparently at Johns Hopkins, they're recommending to do it 4 weeks after vaccination. Frankly, I don't think that we are routinely checking the antibody levels, so we're not entirely sure how to interpret them. But how are you handling questions related to the antibody testing, Warren?
Our recommendations right now are not to have the testing done. We're not sure how it potentially impacts on what we advise patients. I think if patients do end up having a high titer antibody response, we would still recommend that they follow CDC guidelines as far as social distancing and wearing masks when they're exposed in public areas. And the same thing for patients who may not mount an adequate antibody response. First of all, we're not sure what is an adequate antibody response. And we really don't have any literature about what titer would be protective versus non-protective. So I think it just ends up sometimes creating confusion and sometimes creates other additional problems and questions. So our general recommendation has been not to test patients, but I'd be interested to see what some of the other panelists think.
Right, right. I actually agree with you, Warren. I mean, I think that we do need to learn, and if there's a study going on at Hopkins, for example, perhaps that can be helpful for all of us, but it can be confusing in the short term if we don't know how to interpret the information. Yes, so I'm just looking at some other questions that we have here. I'll just switch to something completely different. Oh, no, if you go back up toward the top. Yeah, so just this is something that we'll touch on later, but I'd be interested in the status in Florida, Warren. So this questioner, switching away from COVID, is asking, has Blenrep been widely accepted? And so obviously, belantamab was approved a little bit ago. Has it been possible to get that rolled out in the different groups in Boca and in Florida? How's that been working, would you say?
Yeah, yes, thank you for that question. So, Blenrep certainly is a useful drug in our armamentarium for patients with heavily pretreated myeloma. Once signing up for the REMS program as a physician, which is a fairly smooth process, I think the hardest thing for us in the community has been having an ophthalmologist ready available, as when we do administer this drug, patients need ophthalmology exams prior to each dose, prior to starting therapy, and then prior to each dose, at least 1 week after their last dose and prior to their next dose, they need a good eye exam to evaluate for keratopathy that may be evolving. So we do have access to the drug. We are using it. It is sometimes a little bit of a difficult process getting the right ophthalmologist who understands the side effect of this drug, how to grade it, so we have appropriate criteria for dose adjustment if needed. But it is currently available and being used.
Yes, yes, that's great. I think it's been rolling out at different speeds across the country related to the coding for the reimbursement, actually, plus getting all set up for the eye exams. But this is helpful information for Rafat and Paul as they're talking about the relapse options a little bit later in the morning. Another question about treatment: can Kyprolis be used with Pomalyst and Dex with the Kyprolis once a week? Have you been using this combination locally in Florida?
We have used that combination. We know there's not always going to be phase 3 data for every combination in myeloma, but there is data with that combination. It's been effective. It's been well tolerated. Although I'm not using that particular combination very commonly due to Pomalyst or Kyprolis often now being used together with the CD38 monoclonal antibody.
Right. I'm just scrolling through some of the questions here. Another one, I'm on maintenance with Velcade every 2 weeks. Is it safe to get together with friends who are vaccinated? I'm also vaccinated.
Again, I think that's a tough one because we don't know in patients with hematological cancers such as myeloma exactly how protected they are from these vaccinations. We hope there's enough adequate protection to prevent serious illness. So my recommendation has still been to my patients with myeloma, even if they've been vaccinated and friends have been vaccinated, to follow the CDC guidelines as far as social distancing and mask wearing, at least until we can see much lower numbers of COVID in the community.
Yeah, I actually fully agree. I think I strongly recommend protective measures, even combined with vaccination, especially with the new variants circulating in the community, and if the community level is still relatively high. So I think that wearing a mask is, and we'll talk about this a little bit more later. Yeah. Another question here, how well does the COVID-19 vaccine work if you have MGUS? I don't know if you have any particular perspective on that, Warren.
Again, I presume there were some patients who may have had undiagnosed MGUS on these vaccine trials. And unless there's hypogammaglobulinemia as part of the MGUS, I think hopefully patients with MGUS should mount reasonable responses. But again, I'm not aware of any particular literature.
Right. The only data that's come out related to MGUS has actually been that patients with MGUS who have developed COVID-19 infection, and that's been a relatively small number, have actually done equally well versus what you call normal people without any type of cancer. They've done much better than patients with myeloma, for example, and the outcome has been linked more related to age or any other medical problems that they might have had. Yes, so I'm just looking to see what else we have here. Yes, diagnosed. People, a lot of questions about starting to attend indoor dinners with people who are unvaccinated. We really touched on that. I think that Warren, it seems like both of us would recommend continued caution when you're getting together with people. Right. Question about doing an outdoor wedding with a large crowd. Yes, I think we're talking mostly about common sense here. You know, just be cautious and paying attention to the people around you. Right.
So much.
Can a relapsed patient on active therapy with Dara Landex receive the vaccine? Yeah, so it's just another question related to therapy and getting the vaccine. I think we've mostly answered that. Just to maybe pick a point during the cycle when perhaps off of the lenalidomide and not the same day as the daratumumab. Yeah.
Right, and if patients are in a good remission, it would be very reasonable to just delay the next cycle for a short time period. So there's a little bit of a break between the therapy and the vaccination just to hopefully increase the chance of having a good immune response. So in my patients who are stable with good control of their disease, I may delay their therapy by a few weeks so they can get their vaccines.
Right. Another just related type of thing. How long after bone marrow transplant should you get the vaccine? Yeah. And we touched on that a little bit earlier. Yeah.
Yeah, I think the general recommendation is probably waiting at least 3 months, if not 6.
Right, exactly.
We got the vaccine.
And then there's a question here, actually, I'd be interested. Is a spike in light chains a common reaction to having the COVID vaccine? This has come up a little bit. Questions have come to me. Have you seen any change in myeloma protein levels that you might link to the vaccination? I haven't heard of that, actually, but have you seen any of that?
No, I'm not particularly aware of seeing that. We definitely do see patients develop some local lymphadenopathy sometimes. So from an imaging perspective, if patients are getting PET scans, we try to not do the PET scans too close to vaccination just because of some false positive findings on a PET related to vaccine use. But I'm not aware of any change in myeloma numbers or light chains following vaccination.
Brian,
yes. Yeah,
if you don't mind.
Rafat.
So,
yes,
yeah,
of
my
course.
experience is that you will get a transient rise in kappa light chain. after the vaccination, especially after the second dose, but then it'll normalize a month later.
Okay, that's good to know. Now you specify kappa.
Yeah, I don't know why it's more common. I mean, I haven't seen the M protein go up, or the lambda light chain go up, but for some reason, we see transient rise in the kappa light chain. Couple of weeks after the second vaccination, usually.
Right. Okay. Then actually, we're going to be talking about this shortly. A different question is standard of care induction therapy moving to quad therapy with DARA. So where does that stand, do you think, Warren? Are you using 4 drugs incorporating DARA up front in some initial therapy patients or not yet?
Yeah, great question. So I think that is something that's a hot debate right now until we have data from the ongoing phase 3 trials. We know based on the Griffin trial, randomized phase 2 trial showing the benefit of addition to daratumumab to RVD induction. So I discuss it with patients, and there are some patients who I am using quad therapy. I'm a believer in giving our best drugs up front and not saving them for later on. So I've kind of switched a fair amount to RVD DARA as my go-to regimen for patients with myeloma, regardless of whether they have standard or high risk.
Yeah, interesting. Yeah, so there definitely has been some movement in that direction. And we'll talk about that more later. We'll get the perspective from our other experts on the line here. Yes, let's see if we have any others. A lot of questions still about the COVID vaccine. Yes. But we've really covered it. And you touched on it. A patient is concerned if the neutrophils are low on lenalidomide about getting vaccinated. Yeah, I mean, I think that if your blood counts are low, it might be good to have a rest period and have your blood counts recover before getting vaccinated. And Warren, you touched on that a little bit earlier.
Right.
Yeah.
We would delay vaccination while someone was neutropenic, and then wait till their neutrophil counts probably above 1,000 before recommending vaccination.
Right. Exactly. Yeah. And there's a similar question related to platelets. I guess it's not quite as sensitive related to platelets, although low platelets would also be indicating some suppressed bone marrow function, and so we would be more cautious with that as well. Maybe have some rest period to allow some bone marrow recovery. Yes. Gosh.
Brian?
Yeah. Yes.
So one need to be also careful that, myeloma therapy that include an anti-CD38 antibodies can lower intact immunoglobulin. So although you stop the treatment, but if a patient is heavily, have a lot of myeloma being treated with these therapies, they will attenuate any immune response they have. I mean, as you know, sometimes we even give intravenous immunoglobulin to our patients because their normal intact IgG is quite low. So that's really one of the difficulty, I think, with relapse refractory patients who are heavily being treated to make sure that although we think vaccination is great, but may not be that protective.
Right. No, I fully agree. However, I mean, I know that in some centers they're recommending to to skip, even 1 or 2 months of therapy. And I would be very, very cautious about that. So I think, again, it's just like common sense. I think that we want to avoid and be very much aware of DARA, but I would be hesitant to really delay active therapy for too long.
Brian,
yeah, I'm not saying delay active therapy. I'm just saying that the patient need to be counseled about avoiding exposure to COVID.
Yeah, exactly. Oh, yes, absolutely. Then we have a comment back here where someone is saying that they really feel that it is important to get the antibody levels checked in some situation like a family emergency. If they need to travel, it would be helpful to know what the antibody levels are, even if it's hard to interpret them. And so, every type of situation does have a caveat to it. And so, obviously, I think the bottom line for all of this that we're talking about is that it's very, very important to discuss it with your own personal doctor, because there could be some details of your own disease or your treatment where it could be really important to see what are the antibody levels if there's a real concern about infection if you have to travel. Yeah. Let's see what we have here. Yes. Question about the optometrist. Yeah. So, I mean, I think that with the Blenrep, with the belantamab, it does need to be teed up so that you have the eye checkups done, regularly, once a month, every cycle, I should say. I don't know if there's been any difficulty with that in finding, an optometrist to be able to function close by for that. Has that been something that's difficult to organize, Warren, where you have the eyes checked?
It has been a little challenging. I mean, I've tried to work with one ophthalmology group, but sometimes there's insurance issues and they may not take a particular patient's insurance. But it's important for not for the patient to be the one responsible for getting the eye exam. It's really the physician, hematologist who's taking care of the patient to make sure that patients have access to an ophthalmologist, prior to each dose, and an ophthalmologist who's aware of exactly the side effect of this drug, the type of keratopathy that it causes, so it can be accurately reported back to the hematologist, because there are certain dose adjustments and holding dose depending on evolving keratopathy. Right,
definitely. So this is actually interesting. So another question here relates to vaccination, but this time it's the Shingrix vaccine, and so this does raise an important point. In prioritizing vaccination right now, we've been talking almost exclusively about the COVID-19, but after transplant, obviously there is the revaccination, and then also there's just the Shingrix vaccine. So have you run into this as an issue, Warren, where you might be wanting to give not just the COVID vaccine, but maybe some other vaccines as well?
Right. I mean, we've been prioritizing getting COVID first, and then, making sure that all our myeloma patients also appropriately vaccinated against influenza, not to forget influenza, and also making sure that they've been vaccinated with Shingrix at some point. So, although priorities for COVID right now, also making sure that they've definitely been vaccinated against influenza. And Brian, I don't know if you want to touch base on this, some of the data regarding a second influenza shot for immunocompromised myeloma patients, a month after the initial
absolutely, yeah.
flu shot.
Please comment on that, the booster shot, yeah.
Yeah, it looks like, patients with influenza, again, mount a suboptimal response. And it looks like if they get two separate influenza vaccinations roughly a month apart, that they have additional protections. So I'm generally recommending that for my myeloma patients. I think there's no real downside, and if they get a little bit of additional protection, that's great.
Right, absolutely. And I mean, I think in the big picture, what we're looking at for COVID-19 is that there will be booster shots coming. And so this could be particularly important for myeloma patients. And so we are, I think, assuming that myeloma patients will not have that 100% level of antibody response. And so a booster could well also be helpful related to COVID-19. And in addition, with the new variants coming along, I think I'm certainly expecting that booster shots might become available later in the year, and they might be modified to better cover the variants that have been cropping up. And so with the new mRNA technology, it is possible to rapidly switch to have a modified vaccine. And so I don't know if you agree with that, Warren, that I'm certainly expecting that there will be booster shots for COVID-19, and probably kind of like influenza, that we'll be expecting to have perhaps an annual COVID-19 vaccination.
Yes, Brian, I absolutely agree. And I think just like there's slight adjustments in the influenza vaccination every year, I think we'll have the same with COVID, where there'll be tweaks in the vaccine to cover whatever strain's most prominent at that time. So I think, yes, I agree. I think it's going to be an additional vaccination that we're going to be getting every year for the foreseeable future.
Right, absolutely. Yeah. So maybe a last question is a little bit different. Question is, with bite treatment, what is the patient experience like during bite treatment? So maybe we can broaden that to just say any of the different bispecific antibodies. And so there have been several of those in trials in the last year or so. And so have you had the experience with any patients in any of the bispecific protocols, Warren? Are those open in somewhere in Florida?
I do not have them at my institution, and I think there are some at Moffitt, which is in Tampa, about 4 hours from where we are. But I have no personal experience with the bites at this point.
Okay, so perhaps we can pick that up later. I'll just comment that one of the issues, well, there's a couple of important points, which I'm sure will be discussed more later, is that the first dose of the bispecifics has to be given in the hospital, because there can be this cytokine release response. So there can be a dramatic response with the first dose. Not as dramatic as with CAR T cells, but it can be important. So the first dose is typically given as an inpatient. And then with these bispecific antibodies, it's different than the CAR T, where with the bispecific, it's an ongoing therapy, which can either be intravenous or subcutaneous. And so that's another aspect. And I'm sure that's what the questioner is thinking about, is that there is some ongoing therapy, sub-Q or IV, and that there can be some ongoing impact with side effects, both systemic and with blood counts and the like. So I'll be very interested. So Paul and Rafat, you could be aware to maybe comment on that later in the day. So I think that we've covered quite a lot of different questions, a lot focused on COVID-19. So I think that perhaps we should leave it at that for this particular session, and move on with the program. So Warren, I really appreciate you taking the time to join us today. There's a comment right here, is that I guess Dr. Hoffman has had a bite trial open. So that's good for us to be aware of, that there may be some patient that's been in trials there. So thank you so much, Warren, and
thank you, Brian.
Good luck with your rounds today.
Okay, thank you.
Yeah, really appreciate it. Thank you.
Okay, thank you.
All right. So so I'm going to go ahead with the first session here. What all myeloma patients need to know in 2021. And so I'm going to focus on some details about myeloma, as well as what is obviously a big area of questions, which is COVID-19. And so we will have a chance to answer a number of more questions about COVID-19. Just picking up, and I maybe just comment on it right away, just to be clear, is that with the blend rep, you do need to see an ophthalmologist. So just to be clear about that. So let's move ahead with this first presentation. And so I think that it's key these days, since we are always trying to treat myeloma early and avoid complications from myeloma. What is the story with smoldering myeloma, and where are we in our ability to catch the myeloma really early at a point where maybe it's a high-risk smoldering myeloma, where we think that there is a high chance, and what that means is a 70 to 80% chance of active myeloma within the coming year and a half or so. So next slide. So I think that a very key point right now, and it's a point that many patients have been interested in, is when should treatment be initiated? When should treatment be started? And so obviously, if there are any myeloma defining events. Now, the new diagnostic criteria indicate that if there's a 60% level of plasma cells in the bone marrow, if there's more than one lesion on an MRI, and if the free light ratio is greater than 100. So these events, even in the absence of actual symptoms or signs of myeloma, are sufficient to recommend starting treatment. But obviously, the standard criteria are, elevated calcium, kidney problems, anemia, and of course, bone lesions. So any of those would lead to a start of treatment for myeloma. But what we've been looking at more closely is what about if there are no myeloma defining events, if the levels of plasma cells and free light levels are a little bit lower, for example. At what point would we call it high-risk smoldering myeloma and possibly think about starting treatment? And then on the opposite side, how clearly can we say that someone has definitely got low-risk smoldering myeloma and does not need to be treated in the short term? And so the key things that have been looked at in the last 2 or 3 years are the components of what are called the 2-20-20 system. And so in this system, the cutoff for high-risk smoldering myeloma is if the myeloma protein level in the blood is greater than 2 grams per deciliter, if the percentage of plasma cells is 20% or higher, and if the free light ratio is 20 or higher. And so it's lower cutoffs than for the current myeloma defining events. And so based on recent analysis, these are patients who are also at a higher risk of early progression. Next slide. And so what is recommended if you might fall into this higher risk group where we're anticipating that myeloma could evolve in the coming months? Is it still okay just to observe for now? Perhaps based on trials from Spain and from the Eastern Oncology Group, maybe using Revlimid or Revlimid and Dex could be used to prevent progression. Or maybe it's a better idea if we really are thinking that myeloma will develop to treat it like myeloma, or even using a curative type approach. And so this, at the present time, in the absence of randomized trial data, is very much a personal decision. And we also need to keep in mind that as for myeloma itself, there can be patients who are more elderly or fragile. And so maybe for them, if treatment was considered, Revlimid or Revlimid Dex could be considered. But for a younger, fit patient, it's a lot easier to think about myeloma therapy or even a curative approach. And there are trials ongoing to look at that. For the cure type therapy, there is the ASCENT trial, which is going on right now, which is the DARA KRD approach. And so this is an evolving area, and certainly something to talk carefully with your doctor about. Next slide. But what we're going to be talking about today is the management of myeloma, which has these standard components. You have the initial therapy, and then for patients who are eligible, they will still most likely proceed to autologous stem cell transplant, followed by maintenance. For older patients or those not eligible for transplant, they might receive some consolidation, followed by maintenance. And of course, all these patients will be receiving supportive care with, for example, bone therapy, with Zometa, or with the new monoclonal antibody that can be an alternative. I just reference here, every year, Dr. Vincent Rajkumar has a really excellent overview of management of myeloma, which is a very, very good reference source. Next slide. And so I think that the key thing to be aware of, and one of the most important reasons for having a patient and family seminars like this, is that we have moved from the old days to the new days, where now there are so many options, both in the frontline setting and then moving forward through maintenance to the relapse session, the relapse setting. And so you can see over on the right, there are so many drugs that have been approved and are available. If we start on the left in the frontline setting, I think that for now, as we'll touch on in just a second, a triplet, particularly VRD, is definitely the standard of care. And as we talked about, perhaps converting that into a 4-drug combination along with DARA is something which is more frequently considered. Over on the right, we're going to be hearing a lot about these newer agents, particularly the ones at the bottom of the list. Melflufen was just recently approved. Belantamab just recently approved. Blenref we were just talking about. And prior to that, selinexor was just recently approved. And so these are the newest ones that are available and will be a focus for discussion, I'm sure. Next slide. And so I think that this is a trial which I led, but actually it does highlight the way forward for current approaches to therapy. The SWOG trial, the 777 trial, which was started in 2007, and so this is a trial which has been running for over 10 years now, was the first one to show in an ongoing fashion that starting off with 3 drugs, the Velcade, Revlimid, and Dex, versus just the 2 drugs, Revlimid and Dex, led to both improved remissions and overall survival. And this has been a template for many newer studies here recently, and also the template for looking at 4 drugs versus 3 drugs, for example. Next slide. And so just to show you, I think that it's very, very important, especially for a newly diagnosed patient, to be aware that with the long-term follow-up of VRD with this triplet, that in the SWOG trial, where we have over 10 years of follow-up now, that the initial remission was in that 3.5-year range, and that the overall survival is one in which 55% of the patients are alive at 7 years. And so this is a substantial improvement in terms of outcomes versus what we have seen in the past. Next slide. And so when we're thinking about myeloma therapy, and what we're going to be talking about during the day today is this question of using 3 drugs versus 4 drugs in the frontline setting, and then using maintenance after that, and how that might be modified based upon chromosome genetic testing done at baseline, where it might be recommended to consider using a proteasome inhibitor in addition to Revlimid. And then the approach to relapse that we're going to be hearing about, a more decisive approach to relapse, because excellent results can be obtained, especially if a triplet is used and is feasible. And then, of course, the emerging very powerful impact of all of the new immune therapies. Next slide. So that kind of sets the stage for today as we move forward. Just a few summary comments about COVID, since there are just so many anxieties and concerns about the COVID-19 pandemic. Next slide. So to be very, very clear, I think that we've talked about what is the response to the vaccination in patients with myeloma. And probably it is somewhat suboptimal, but that doesn't mean that you shouldn't get vaccinated. It's very, very important to get vaccinated as soon as you can with whatever vaccine is available to you, if that be the Pfizer, the Moderna, or the recently approved one-time dose J&J vaccine. And so I think that even if there is a suboptimal response, what we know is that it is probably good enough to really reduce the risk of developing severe disease, which is what we're trying to avoid for every myeloma patient. And also that this is just the first step to protect both the patient and the disease in the community. And we're expecting that booster shots of some type will be introduced later in the year. For myeloma patients, no, stay on this slide, yes. Should continue to wear masks in public settings. Absolutely, I recommend that. And it's still not safe to be traveling on planes or trains, because there are just too many people around that you could have contact with where you could have a chance of being exposed to infection. Small protected gatherings are okay, getting together with grandkids if you've been vaccinated, some of these things that have been in the news these last few days. Next slide. Yeah, and so some of the strategies to reduce risk during the crisis, obviously many of you have been using telemedicine to avoid some clinic visits, and perhaps limiting lab testing or getting lab testing done locally. Maybe you did reduce the number of doses of getting the Zometa, and be more cautious about low blood counts. As we were discussing, we don't want you to be having low blood counts, neutropenia, especially if we're wanting you to have vaccination, and maybe consider oral drugs versus IV drugs. And be especially cautious about DARA because of the reduction in the immune system. And as we mentioned, as Rafat emphasized, just be aware of that. Be aware that clinical trials are still going on, although there are different priorities at different centers, and trials may be modified based on the COVID-19. Next slide. Yes. One of the key things is just to be aware of different things that are okay. And obviously, going out and about with your mask on is strongly encouraged. Go for a walk. And if you need to see the dentist, it's definitely okay. The setup in dentist offices has really been tightened up considerably, and it is mostly quite safe to get routine dental work performed. Next slide. But the big thing right now, which is affecting all of us, is pandemic fatigue. I'm just using this phrase. It really has been a long haul this last year, being locked down, being limited with social contacts. And this is a real issue for everyone. And so to avoid problems, it's so important to reach out to family and friends on a regular basis. Try actively to find ways to de-stress. You can go on a virtual tour of the art museum, or what is even funnier is to look at the penguins from the Shed Aquarium, where they're allowed out and about once a week now, and they actually went to the art museum in Chicago, and watching them go to the art museum is especially funny. And I strongly recommend clicking on that video. There's a whole series of them once a week. But we all need to try to be stronger, and it is important to try to work on your resilience. We're not going to be resilient every day, but we had a Living Well call with Dr. Sue Dunnett from the University of Edinburgh, where she talked about how we can focus on this and try to build your resistance during these difficult times. As I said, you're not going to be resilient every day, and don't expect that. But if you work at it slowly, it is helpful to try to build it up. Physical resilience so that you have good strength, but also mental resilience and reducing stress. Next slide. For the support groups, many of you have been participating with your virtual support groups, and Susie and I have been participating in those, a number of those, and these I think have been especially helpful to overcome this fatigue and allow people to connect. Next slide. I think we have some more pictures. Yeah, so you can see that this has really helped people to really connect and learn, but to stay socially connected right now, which has been crucial. Next slide. And so we will get through this together. We will get through this together. Myeloma has no borders, and nature is a reminder, a constant reminder that life goes on. And as David Hockney said earlier last year, remember, they can't cancel the spring. And he was talking about this as the daffodils were popping up despite the emergence of the pandemic. And so nature is a big reminder of the resilience that surrounds us every day. Next slide. And so the pandemic is a big problem, and we certainly want to work to prevent it from happening again. It's complicated, but standard preventive precautions work. Wearing a mask is so helpful. We need to adjust your myeloma care, but we really want to focus on making sure you still do get your care. As we said, there will be a long-term impact, which mostly will be a need for ongoing vaccination, I think, for sure. Next slide. And so we have different seminars for the newly diagnosed and for COVID, and many different sources of information, and we do to take advantage of those. Next slide. All right, so I'm going to finish there, and I'm very pleased to introduce Donna Catamero, who is going to go into a bit more detail about supportive care in this time of COVID-19. And this is, as I've been emphasizing, just so important to look at these different aspects. Donna has a tremendous experience. She comes from the Mount Sinai system in New York, and so she really had a lot of hands-on experience, and I'm sure she has a lot of words of wisdom to convey to all of us. So please welcome Donna.
Thank you, Dr. Durie. It's actually a pleasure to speak with everyone this morning. As Dr. Durie said, I'm Donna Catamero at the Mount Sinai Hospital in the heart of New York City. And then last spring, I think we became the center of the epicenter of COVID-19. And literally everyone's lives turned on a dime. Our routines just drastically changed overnight. So I just know that this past year has been very trying for everyone. It's been a year of significant loss and isolation. But despite this, as myeloma patients, we need to carry on. So know that you have a network of friends, family, and your healthcare team to get you through these trying times. And I just want to stress, a recent study from the American Psychological Association reported that over 50% of Americans had either canceled or postponed, their health appointments, their medical appointments. So of course, I encourage everyone to continue on with their care, continue with your routine follow-ups and your treatment plan. But because of COVID, in many institutions, we are limiting visitors. So in many instances, you may find yourself attending your appointments or your treatments by yourself. So you want to make sure that you are prepared. Write down your questions and your concerns and even your COVID concerns prior to going. You want to make sure that you can tell your healthcare team any changes since your last visit, and any new symptoms, no matter how insignificant they might seem to you, please share them with us. And at the time of your appointment, you'll never hear me say this enough, please bring your mask. But I think a lot of the centers are able to give you a new mask if you forget one. And then with your questions, make sure you ask the most important questions to you first. And then make sure you understand your treatment plan. It's okay to ask your providers to repeat it multiple times, and then you want to make sure you repeat it back to them so there's a mutual understanding. And then because of visitation restrictions, again, you might be alone in that exam room. It's okay to have a loved one or a caregiver on the phone to have that second set of ears. And then when you're at home, try to stay healthy, take care of yourself. Over 40% of Americans during this pandemic have reported significant weight gain. So that's over 25 pounds in a year. And another over 60% of Americans have reported some type of sleep disturbances during this pandemic. So, really you want to communicate with your healthcare team in between visits and see how we can help you get through this. So telehealth visits, we're utilizing them more and more given this day and age, and they're really equivalent to an in-person visit. Though there are some tips when you are doing, if you want to participate using a telehealth visit. First, you want to make sure that you have the appropriate technology, whether that be an iPad, smartphone, or a laptop. You want to make sure that you have a web camera so you can, communicate and see each other. You want to make sure that you plan ahead. Make sure that you know how to log on to your appointment and what time you should be doing that. You want to make sure that you're in a quiet, well-lit place with good Wi-Fi. You do not want to be in your car speeding down the highway. That is a big, big no-no. And then finally, you want to be prepared for your appointment. So prior to your telehealth visit, you should be getting any necessary lab work so that your visit can be fairly predictable. So this slide just shows, on a scale of 1 to 10, how risky is our activities. And so what makes an activity risky? So it depends on many factors, and you have to ask, in your community, in your setting, in your state, is COVID-19 spreading? So it's important to really be up to date on the positivity rate in your area, and then ask yourself, will I be in close contact with someone who is sick or not wearing a mask? Am I myself at high risk for developing severe illness, or maybe someone that I live with? And then will you be sharing items or equipment during the activity? And then what makes an activity safe? So can you maintain that 6 feet of social distancing? Will this activity be held outdoors versus indoors? And then will people be wearing masks? So that you won't hear me say that enough. Masks are important. They prevent disease and serious illness. So I think we all know this. The best way to prevent illness is to avoid it. So I think we all know that COVID by now is spread through respiratory droplets, which are produced by coughing, sneezing, and talking. And then just things to keep in mind, when we're yelling or talking loudly or even singing, there are more droplets produced. So that 6 feet of social distancing may need to be spread out even further with those types of activities. And just know that droplets can land in the mouth and the nose as well as the eyes. I think we're all aware that COVID-19 can be spread by those who are not exhibiting symptoms. So just keep that in mind. So reduce your risk. And these are common sense rules. So back at the peak of the pandemic in New York City, I was redeployed in infectious disease. And our morning mantra was, wash your hands with soap and water. That really is the best way to wash your hands. But of course, we don't always have access to a sink and soap. So hand sanitizer is 100% appropriate. Just make sure that it's at least 60% alcohol based. Of course, maintain social distancing. Wear a mask, wear a mask, wear a mask. I don't care if the people around you aren't, just please wear a mask. We know that they work. And prevent other illnesses. So please be up to date with your seasonal flu and your pneumonia, because the last thing you want is to have COVID-19 on top of a seasonal flu or a pneumonia. You want to clean and disinfect high-touch surfaces, and of course, try to avoid travel on planes and trains, and definitely cruises. So masks. So you'll hear me talk about this a lot. You want to choose an appropriate mask, so something that's breathable, at least 2 layers, preferably 3 layers. And you want to make sure it covers your, completely covers your nose and your mouth, and has a nice snug fit on the side of the mouth, on the side of the face. What makes a bad mask? So those masks that are not made from those breathable materials, they're making these masks now that are vinyl, so that you can see somebody's face. Although the intentions are good, vinyl is the worst thing to breathe through. Next are these masks with these exhalation valves, and I like to refer to these masks as selfish masks, because it's actually your droplets are escaping and could potentially affect others. So these really aren't great masks for stopping the spread. And then finally, N95 masks should truly be reserved for healthcare workers. A good alternative to an N95 mask is a KN95 mask, which are very similar. And they're masks made from Asia and can be readily purchased on sites like Amazon, which I think they are good masks. Just be cautious with neck gaiters. I really don't think they're effective at all. They're typically only 1 layer of material, and they don't provide that snug fit around the face. If you do like neck gaiters, I would recommend folding them, so at least you have 2 layers of protection. The next is face shields. So the primary purpose of a face shield was to provide eye protection. It is really not to be used in exchange for a mask. So you really should be using a mask and a face shield to provide you with eye protection and eye protection only. And another thing we're seeing more and more is people are wearing double masks. The purpose of a double mask is it provides a better fit around the face, especially now that we have more contagion variants circulating across the country. So it gives you a little more protection. So the proper way to wear two masks is to have the disposable mask underneath the cloth mask. And just please remember to frequently wash your cloth mask, because I know people are wearing the same cloth mask day after day after day and not washing them, and that can be kind of dirty. So just make sure you do frequently wash your cloth mask. So wear your mask and wear it correctly. So again, we want to cover the nose and the mouth. There are so many times I see people with their nose peeking out of their mouth, out of their mask, and it's essentially like not wearing a mask at all. It's providing you no protection, and it's not providing protection to others. So please, when you do wear a mask, cover your nose and cover your mouth. So I want to end about stress during this pandemic, and I know Dr. Durie touched on this. We know that it's been a very stressful time this year, and 50% of Americans have actually reported that their mental health has declined over the past year. So in addition to, significant weight gain that we're seeing and sleep disturbances, more and more Americans are reporting an increase in alcohol and other substance use. So it's important for us to take care of ourselves. So identify your bad habits, your bad behavior, and try to change them. And I know that can be easier said than done. I think this past year, many of us have stayed indoors, sat on our couches. I think probably Netflix was probably the best thing since sliced bread. So, but the weather is getting better. There are more opportunities to do activities outside, go take a walk, go outside and do some safe activities. And then finally, isolation has been a big issue with patients and people in general. So connect with others. And I think Dr. Durie brought up the point of support groups. FaceTime is better than no time, and really connecting with one another can really help us through. And I'll just end by saying, the light is getting brighter. We're almost at the other end, or the other end of the tunnel, the proverbial tunnel. So I think life will slowly get back to normal, hopefully by the end of the year. So, and with that, I'll end.
Just try to pick up on some of those. Is it necessary to wear a face shield if you wear glasses? That's one sitting there. Do you want to answer that one, Donna?
Yeah, so I know it's very difficult for people who wear glasses, I myself, and they sell face shields now that go nicely over glasses, but I don't think it's something that we routinely would wear eye protection. It's really for healthcare providers when they have close contact with sick patients.
Yeah, right. There's a tip here. A drop of liquid soap spread on the inside of lenses prevents fogging. Oh, that's a good tip if it's true. I don't know.
Yes, it actually works. It works.
Does that work?
It works. Trust me.
All right. Well, that's a good one. That's a new one for me. So it says not all. This I'm aware of. Not all K95 masks are created alike. Some are virtually useless. Yeah, I think you touched on that. I mean, some real N95 masks. You can get them online now. I don't know what suggestions that you have, Donna, in terms of sourcing to get the best mask.
So I was just fortunate that I actually have colleagues that live in Korea, in Japan. I found that the Korean and Japanese KN95 masks are of good quality. So I would look to see if they were made in those two countries.
Yeah, I would agree with that, actually, yes. Yes. Now, this is an interesting one, actually. Is it safe to stay in a motel? I mean, we're telling people that they shouldn't travel in planes or trains or go on a cruise. But if you're driving and trying to take a little trip locally, how about staying in a motel? What do you think about that?
I don't disagree with it. I think traveling locally within your tri-state area, I actually, when I do travel, I bring my own wipes, and I do wipe down anything that's highly touched, so the remote control, etc. But again, you are isolating yourself in your family bubble. I think it's a relatively safe activity, but I do that extra spot cleaning because I'm neurotic.
No, I think maybe not so neurotic. I think it's probably a good idea to do that spot cleaning. Yes. Now, this is a practical thing that has affected many people, especially women. If both you and your hairdresser are wearing a mask, is getting your hair cut and colored safe with a 90-minute appointment? What do you think about that?
So underneath this brown hair is actually white hair. So there was, this is such a touchy subject because, yes, as a woman, I know. There was, I forgot what state it was, maybe Michigan, where they opened up the salons a little bit earlier, and two of the hairstylists were tested positive for COVID. However, none of their clients tested positive. They were both wearing masks, but just know it is on a higher risk level. But it's like I can't practice what I preach because, of course, look at me. I'd be fully white-haired if I didn't dye my hair. But just common sense rules. Both should be wearing face masks, and I'll leave it at that.
Right.
You can fully disagree with me, Dr. Durie, but no. It's hard being a woman.
Actually, we're talking about the stress and the problems, and I think that being able to go and get your hair colored, I think, is a significant stress reducer, and I think that is of substantial value in itself. That's my personal opinion. Now, there's also a question here about ventilation in hotels. I think that this is going to be an increasingly important issue as things start to open up. I think that paying attention to ventilation is a concern, and I'm already seeing that there are some hotels and motels where renovations have been already conducted to try to improve the ventilation. And there's even a system for a company, actually, that is kind of grading buildings and hotels related to safeness, including ventilation. Are you aware of that, where there's more of a grading system coming into play for larger buildings or hotels? Do you see that in New York at all?
I actually had to travel up to Boston, and the big chain hotels are putting these air purified ventilation into each room. So there's a unit that they put into each room. So I would call ahead to see, the hotel that you're thinking of staying, to see what kind of precautions they put in place. But I am seeing the larger chain hotels making these adaptations.
Right. So then we talked about getting your hair done. Then it says here, my husband and I have both been vaccinated, and now he wants to start to go back to the gym. Now, that's good. However, if everyone's not wearing a mask, how about that? I think that gyms can be problematic. Fortunately, out here in California, a number of gyms have been using outside spaces, and so that has been and is becoming rather popular, where people are going to the gym but outside in a sort of an open, slightly tented area. But what do you think about that, Donna?
Yeah, so New York, we do get 4 seasons. So the summer and fall, there were a lot of outdoor classes where they spread people out. Where I am in the metro area, still we have a mask mandate, and you can't work out without a mask. What we've been telling our patients is, to figure out when the least, the lowest volume of people going into the gym. And
right.
When it's not so busy, maybe that would be a good opportunity. And again, face mask all the time. I know it's not the most comfortable when you work out, but it's for everyone's safety.
Right. Look, we have a lot of questions about masks, and I just have to say I fully agree with you, Donna. I think that despite vaccination, despite all these different things, it's still important to wear a mask until the level of community infection is definitely lower. Yes. Apparently, the CDC has a list of the best masks. I think that is true. I've seen that. Yes. So that can be checked out as a source of information. That is correct. Yes. There's a question. My sister had COVID. Can I see her freely? This actually is a tricky question. I mean, I've had that question from a number of patients where family members have actually had COVID, and then maybe some weeks later, question about getting together with that family member. Have you encountered that quite a bit?
Yeah, and I saw a question too come through, like, can I hug my grandchildren? And these are all heartbreaking questions. The CDC is recommending, people who are both vaccinated can conjugate in small groups. Just be aware that there are variants, especially in Florida, that they both have the UK variant and the South African variant that are more contagious. And that's why you see more and more people double masking. I don't think we're out of the woods just yet. So I'm hoping by, early fall or even sooner we'll reach herd immunity and things can get back to more of a normal life.
Yeah, I really second that. I think that with the dramatic speeding up of the vaccination, with the release of more vaccine, more and more people getting vaccinated, I think that this is really encouraging, and I think that it will steadily reduce the level of community infection and reduce the risk of generally being out and about. And so I'm definitely, for the first time, a little bit more optimistic. I will just say here in Los Angeles, we have been in lockdown, it seems like forever. But just yesterday, some of the restaurants opened at 25% capacity, and which I think is, with care, is probably safe. But I mean, we're sensing some elements of returning toward some degree of normal. So there is some light coming. So that's good news. Before we finish up in this segment, we have our panelists, I think, available. I don't know if you have any strong words of wisdom about COVID-19 from your experience that you would like to give us at this point. Yelak, from a patient perspective, or Paul or Rafat, are there any strong points you'd like to make about the COVID pandemic? No? That's fine.
Sorry, guys, I don't know if you can hear me.
Yes.
Sorry, I don't know if you can hear me, guys. It's Paul here.
Yeah. Yes, Paul.
Oh, yeah. Yeah. No, I was just going to say, I think Donna captured it very well. I think the challenge for COVID-19, you addressed it very comprehensively. I think the issues of precautions and being careful are essential, because what we're realizing is the degree of protection for all patients with hematologic cancers is a concern from the vaccine standpoint, but also that patients with hematologic cancers are vulnerable to COVID-19. So I think we need to be obviously optimistic, but also be very careful. All my patients are being vaccinated. Some patients are seeing antibody responses, some are not. Good news is that you have innate immunity from T cells that can protect you. But again, we're learning an awful lot about how much protection there is, how much there isn't. So I think it's a very dynamic area where we're learning more. The good news is, though, that the therapeutics in COVID-19 are improving dramatically as well. So I think to echo Donna, there's a strong message of hope, but I think to be very careful. And like you, Brian, I'm concerned about the variants and what they mean.
Yeah, absolutely. So I think that the variants obviously spread much more easily, and so I think that reinforce the point that you've made, Paul, which is that have an excellent antibody response, others maybe not so much. And so it is still quite important to maintain the precautions, to wear masks. I actually like the idea of the double masks, which are actually quite comfortable, so that that can really reduce the risk of spread, especially with these new variants. And so I do think that we're going to be seeing mask use for quite a bit of time for myeloma patients, just to maintain this level of precaution. Okay, so I think that a lot of great questions in this opening session, and so I hope that it's been interesting and helpful and educational for our listeners and participants. And so we're going to take a short break now, and then we will be coming back to talk about both immune therapy and the broad approach to relapse therapy, and then the perspective of the patient. So stretch your legs and take a bio break, and we will see you back shortly. Thank you so much. We're very pleased to continue with the next segment of the program. I think that although we're very much focused on how to handle the COVID-19 pandemic, these are extremely exciting times in the management of myeloma, in the research of myeloma, and particularly the evolving role of the immune therapies, treatments that work with your own immune system, and as we touched on earlier, CAR T cells and bispecifics, really exciting area of research and treatment. And so it's just fantastic that Paul Richardson is available and able to be with us today. And so please, Dr. Paul Richardson from the Dana-Farber in Boston, very grateful for your presentation today.
Great. Thanks very much. Hello?
There you go.
Hi, Brian, Susie, a very good morning in LA, and actually still morning here in Boston, actually. It's lovely to be with everyone. It's one of the highlights of the year, and I certainly will not forget last year when we presented just as the pandemic began. And really to echo something that Donna so nicely said, I think we do see true light at the end of the tunnel, but like all of these things, it's a marathon, not a sprint. And I think for us as myeloma caregivers and patients, we can certainly relate to that. Having said that, to echo your point, Brian, the optimism in myeloma is real, because despite the enormous challenge of the pandemic, progress has been remarkable. And in that regard, what I wanted to do today, really on behalf of colleagues who've really led the field in immunotherapy, is frame that for our listeners and at the same time discuss with you some of the innovative immune therapy that may not be quite so obvious, such as the impact of cellular modifiers, the so-called cell mods. I'm going to touch on those as well. So in that spirit, these are just my relevant disclosures. So as we think about key targets in myeloma, I think it's very important to help frame the conversation by addressing the issue that this disease is incredibly genomically unstable as an entity, and therefore the targeting and overcoming of mutations is a primary focus in myeloma research. And in that sense, there is a critical role of combination and continuous therapy. And Brian, I thought you framed it beautifully earlier. You know, for example, the regimen of RVD is a paradigm from the beginning of development, which obviously we led in 2006 to your pivotal trial that followed. We've seen a remarkable outcome from the 3-drug platform of proteasome inhibition, immunomodulation, and steroids. And now, of course, with the RVD-DARA paradigm moving forward as an example, and of course also the success of KRD, we've realized that this combinatorial strategy plus an antibody is changing people's lives and dramatically improving prognosis. And I was particularly impressed to see the long-term follow-up of SWOG 777, very similar to the long-term outcomes that we've seen from our original early phase studies over 10 years ago. So again, really important hope for our patients. But beyond that, the challenge then becomes, well, where do we go? And I think it's important to recognize that there's an evolving position and timing of transplant, which I think is very exciting because obviously we're learning very quickly that one size does not fit all when it comes to transplantation, and that high-dose melphalan, great as it's been for many, many years, the position of that particular approach is changing with the success of these other combination strategies, and the fact that we can offer now to our patients the delayed option of keeping transplant in reserve and using it when necessary, as opposed to, you know, in a more algorithmic fashion that could be considered now perhaps somewhat outmoded. So with that in mind, what are the sort of new directions that we're heading in? Well, obviously a cornerstone of what we've been doing is targeting excess protein production, all the forms that that takes, be it with proteasome inhibition or, for that matter, in the context of protein degradation strategies and others. But critically, the restoration of immune function in myeloma patients has been recognized to be fundamental. And immune suppression in myeloma has been a frontier from the very beginning, obviously. But now we have real strategies that can be targeted at overcoming it. Now, why this is so important is summarized in this slide. I'm very grateful to my partner, Nikhil Munshi, for sharing this with me. This is a whole genome sequencing profile on one of our patients who undergoes initial diagnosis. This is on the left of the slide. You can see complex genomic changes at diagnosis, and this patient actually has over 5,000 mutations in the genetics of their cancer at diagnosis. This patient then undergoes induction remission therapy with RVD, as it happens, and then followed by high-dose melphalan, further treatment, and then maintenance, and then unfortunately relapses. And at the end of that point, when we looked at the whole genome sequencing here, you can see the number of mutations dramatically increases to over 12,000. And this gives you one arrow. This is from Nikhil, showing one targetable mutation in this particular case. But I show this because you can see the challenge is, well, that's great that that's targetable, but look at the rest of this. You know, we're dealing with 12,000 mutations strong in this patient's disease. How on earth do we shut this process down? And so as we think about how our drugs work and think about how we throw a big net around this, and we'll hear in a minute from Rafat in more detail about strategies in relapse refractory disease and why this so matters, I think it's very obvious from this picture, it sort of says 1,000 words in my view, that strategies such as immune treatments that can grapple with the wholeness of this problem and shut it down clearly intuitively make great sense. Now, I'm just going to, slides are jumping a little bit. This is actually just an algorithm that I just want to share with you, which I think sort of illustrates the point I'm trying to make. We should think about immune therapies in two ways, active and then arguably sort of passive. And I would say the active strategies are those designed to act on the immune system itself, and the passive ones are those designed to act directly on the tumor. Now, we'll hear in a minute from Rafat about anti-tumor monoclonal antibodies. He's also going to talk about antibody-drug conjugates. I'm going to touch on those as well, simply mechanistically, because I think they're a very important strategy. And also, of course, I've already mentioned the immunomodulatory drugs. We'll go a little deeper into that with the discussion on the cell mods. But of course, my focus in the interest of time today for everyone is really on adoptive therapies, cell therapies and adoptive T-cell therapy in particular. But I would be remiss if I didn't mention, obviously, the importance of vaccines, which we're in the process of developing, especially in the smoldering setting or early stage setting, where I think they have potential real opportunity as well, arguably, in the post-CAR T setting of re-educating the immune system. And after all, we've been talking all morning about the importance of vaccines in COVID. And needless to say, one of perhaps the gains of the COVID tragedy and all that's gone with it, though, is our ability to really think hard about the vaccines that have come out from this extraordinary response to the COVID disaster, and then be in a position to think, well, maybe some of the lessons we're learning there could come across nicely into myeloma. But the good news is we already have vaccine strategies well underway. Now, just because before we get too fizzy about immune therapy, it's worth mentioning the cautionary tale of the checkpoint inhibitors, where checkpoint inhibitors initially showed great promise, but actually as good, and the complexity of this process became very clear. So I think as we think about immune therapy, it's important to bear in mind that this is an incredibly fast evolving field. But the good news is there are very promising strategies, but also to remember that some things are more challenging than others. Now, in terms of immune surveillance in multiple myeloma, we know this really matters. We know that there are multiple pathways through which these work. And again, I just show these by illustration, and they'll be available to all our listeners to review at their leisure in more detail. But I just want to emphasize the point that you can restore host immune surveillance, which is essentially the platform of the CAR Ts I'm going to come to. I want to emphasize the immunologic effects of myeloma therapies, and we'll touch on those in particular in the context of cell mods, but it's important to realize immunomodulators do that already. We've already discussed the vaccines, and then, of course, there's the strategies of antibodies, which Rafat is going to spend some more time on in a moment as well. Now, in terms of adoptive cellular therapies, a couple of points to make here, and I just want to acknowledge my colleague, Dr. Adam Sperling, who very kindly shared this particular slide with me, because I think it's very clear-cut and very, very, very informative that when we think of adoptive cellular therapy, what we're really looking to try and do is re-educate a patient's immune system, and in particular their T cells, to then target disease accordingly. And CAR T, of course, has been a paradigm of this in a highly sophisticated fashion through T cell collection, T cell transfection, in which basically the antigens that we need to target are then integrated into these T cells. These T cells then are transferred back to the patient, and in anticipation of that, lymphodepletion may or may not be necessary. And then after that, there is a highly sophisticated approach to patient monitoring, both in terms of disease response and CAR T persistence, as well as management of side effects. So this, in a nutshell, is the construct between how the CAR T process occurs. Now, I want to, again, not to blind people with the science, but simply to illustrate the sophistication of this approach. Chimeric antigen receptor T cells, or CAR T cells for short, reflect both an extracellular domain, a transmembrane domain, and an intracellular domain that applies to how to manipulate, in particular, the T cells involved. And there are first, second, and third generation CARs. Now, again, not again to make this unduly complicated, but just to understand that this is a rapidly evolving space where essentially in the first generation CARs, we looked at what we would call T-cell co-receptors and T-cell activation being key. The second generation receptors then went a little further by generating what we call a co-stimulatory domain. And the third generation now are so exciting because they include two co-stimulatory domains. So the rationale is to yet further enhance the ability of the immune response to go after the patient's particular disease. Now, the target antigens in multiple myeloma are summarized here. And please, again, don't necessarily worry too much about the details, but simply just know that we have several: CD38, CD138, CD19, the kappa light chain, SLAM F7, BCMA, and a very exciting new one, GPRC5D. And clinical trials in all of this are now underway. The important message here is that whilst I'm going to focus, for the interest of time today, on BCMA primarily, to know that a variety of these targets are being pursued broadly. I think we're all very familiar with CD38, and again, Rafat will spend time on that in a moment. Perhaps people are a little bit less familiar with CD138, but interestingly enough, CD19 was one of the first targets exploited in myeloma patients, and we'll come to that in just a moment. But most of the work to date has been done in BCMA. Now, in terms of CD19, this is actually illustrative of a patient who actually we cared for at Dana-Farber as well as at UPenn, patient of actually Dr. Anderson's. And she had a history that's summarized here, as you can see, relatively classical in the sense that she underwent autologous transplant, lenalidomide, bortezomib, dexamethasone, so RVD-based therapy thereafter. She also had other combination novel treatments at the time, and then ultimately was effectively cytoreduced at UPenn with a second intensification and went on to receive a CD19 targeting CAR. Wonderfully, she had a great response, and actually this was very exciting to see. It didn't last terribly long, unfortunately, about a year, but then when the disease came back, we were able to control it much better because by that time we had daratumumab and other strategies, and she did much better in the long term and continues to do so. The important point, though, is this was our first excursion into CAR T therapy in myeloma, and whilst promising, CD19 actually did not translate for the other patients as particularly beneficial. So BCMA was the next on the block, and this has obviously been much more exciting, and we'll go into much more detail now. BCMA is a so-called member of the TNF receptor superfamily. I think it's best just to remember it as a B-cell maturation antigen. And the good news is that its expression is largely restricted to all plasma cells and some mature B cells, which provides a degree of selectivity. And what you can see on the right of this slide is the brown staining is the BCMA protein in a mass of plasma cells. And so this provides us with an ability to go very directly after BCMA. Now, the best platform for this so far has been the BB2121 platform, so-called ide-cel. It's the most advanced and hopefully will be FDA approved as soon as the end of this month. This takes an autologous CAR T cell, and then with a co-stimulatory domain, as well as the intracellular signaling domain, has been able to be successfully targeted to patients with relapsed refractory myeloma. It shows the phase 1 design, again, not to belabor this, but just to acknowledge the tremendous work from investigators in this field, led by my colleague, Dr. Nupa Rajay. And this paper was published by Nupa and her team, including colleagues from our own center, and particularly my partner, Dr. Nikhil Munshi, in the New England Journal a couple of years ago. And in fact, we saw very promising results from this at the time. And Nikhil just published, in fact, about 10 days ago in the New England Journal, the phase 2 experience of the so-called KarMMa-2 study, where this was taken into a larger setting and really showed impressive clinical benefit for a much larger group of patients. In fact, the overall response rate was around 75%, and the median duration of response was approximately 11 months in this large phase 2 study, pointing to the fact that you can engender high-quality response that's durable, again, with the single approach. This requires no necessarily maintenance to follow or anything like it in these trials, simply just the approach. And these were, of course, in penta-refractory, highly pretreated patients. So the signal there very encouraging, and further studies are now ongoing to take this further into earlier settings with this approach with the BB2121 platform. Now, one of the challenges is a so-called cytokine release syndrome. And I want to emphasize this because it seems to occur more broadly with immune therapies. And obviously there are various ways of grading this, but in its severest forms, it can be extremely challenging. The good news is that we've become much better able to understand it on the one hand, and at the same time treat it. And so this has fortunately become much less of a problem for the BB2121 platform that it may have initially raised itself as being early in the development of these platforms. So the good news there, generally manageable and relatively low rates. But we do realize that this is an important challenge going forward, and we're looking at another novel strategies to try and minimize this as a late complication. Now, in that same spirit, the cilta-cel platform, which is led by Janssen originally, the Legend platform from China is where this technology came, is incredibly powerful. It's again an autologous CAR T cell, but basically it has 2 BCMA targeting sites, which gives it additional potency, as well as these 2 domains. And again, the signal derived from this particular approach has been particularly impressive, actually. And what's basically happened is we've been able to show this to be extraordinarily active, with a very high response rate, and very importantly, also associated with durable disease control. One of the challenges, however, has been that there is more toxicity associated with this particular approach. So this is an area of increasing focus and intense investigation to better understand how to minimize the toxicity and yet preserve the efficacy that's been seen. So again, the so-called CARTITUDE studies, CARMA is for the BB2121 studies, CARTITUDE is for the cilta-cel platform, and these studies are ongoing. Now, I want to touch briefly that there are other platforms as well. I'm not going to be, in the interest of time, talking about every single one, just to give you a sort of smorgasbord of those that are currently under study. There's one by the CARSgen team, the so-called CT053 CAR, which is looking very excitingly at a similar targeted approach, but with additional nuances for patients with relapsed refractory disease. And again, preliminary results are very exciting from this approach. And I think what I rather like is the poetry of all of these studies. This is called the LUMICAR study, which is looking at just this approach. And the initial response data are particularly attractive. As you can see, 94% of patients responding, including some very high quality responses seen. And this is obviously an exciting early signal. Now, if you look at the summary of the CAR-T approaches overall, I've tried to summarize them on this slide, but what you can see here is that this has been taken on very broadly by a number of important platforms, and the early data are very promising. And what we're hoping to do is minimize the side effect profile and maximize the benefit. But as you can see, really from the construct of the duration of responses, they're encouraging at approximately a year. Median progression-free survivals are also good. But this raises then a critical question of how do you maintain responses with this approach? And so future directions include new antigens, new CARs, and we'll touch a little bit on this in a moment. Also, we need to be sure that with these CARs, there's an ability to rapidly manufacture, because one of the challenges has been to be able to move quickly to other platforms and deploy these platforms for our patients who obviously need them fast, not to be on waiting lists that last many months. And obviously, there are other strategies of combination therapies and maintaining remission. One particular target on BCMA I just want to touch on, just to especially acknowledge my colleague, Eric Smith, was at Memorial, and now we've been very lucky. He's come to us at Dana-Farber. He's a brilliant scientist. He's identified GPRC5D as a very important target in myeloma. And early data from this particular approach are particularly attractive. And then just on a lighter note, just to raise a smile, there's another CAR called a BAT CAR, no less, which is a binary activated T cell with a chimeric antigen receptor. And this is under study and coming into clinical evaluation. And the simple point for sharing this is that these are a very exciting new direction for our patients with immune therapy, with some of the early results being, I think, quite unprecedented in terms of quality of response and depth of response. And what we're really hoping is that this will translate into real-world benefit for our patients with the eagerly anticipated FDA approval of ide-cel later this month. Now, beyond CAR-Ts, what about bispecific T-cell engagers? These are so-called BiTEs. And basically, this is a different approach because it doesn't necessarily require the T cells to be taken out of the body and given back. This tries to do it all within you. And the very good news here is that, again, this has become a very exciting area of research. And I summarize here some of the critical studies that are currently ongoing. There are several in the mix. And I'm going to spend a little bit of time on each of the ones that are probably most mature. But what you need to see from all of these, and they range from a very large study in phase 1 of almost 150 patients strong to smaller studies of 50 to 40 patients or so. But these particular approaches are showing very high quality of responses, but at the same time also a manageable tolerability profile, recognizing that CRS is an important one to be on the lookout for. Now, again, not to blind you with the science, but simply to emphasize a point that actually Brian made earlier, that these are approaches that can be originally used in the hospital setting and then move quickly into the clinic thereafter, and are typically repeated every 2 to 4 weeks or so, depending on the nature of the particular BITE platform. But what we're learning here is that by using these multi-targeted approaches in terms of bringing together both the BCMA target and the CD3 antibody, we're seeing dramatic responses in patients. So what I showed you just a moment ago was preclinical data to support this particular BITE going forward. And this was lovely data presented by Dr. Rodriguez and colleagues at ASH. And what you can see here is that the overall response rate was 80% in doses that were considered active. And this was actually a Q3 dosing schedule with only 48 hours of inpatient requirement at the very beginning. So this is a very exciting platform. And similarly, when we look at other approaches, the data preclinically are extremely exciting. And in this context, again, this was actually lovely data presented by Dr. Garfel, who's very well known in the CAR-T space as well, where he was able to show with this particular approach that he does a 73% response rate, including high-quality responses. So yet another platform, again, showing benefit in this setting. Not to be outdone, the GPRC5D target, this is not BCMA, I want to stress to add, but GPRC5D, and this is very important because if BCMA has already been used, this target then becomes very important. This was excellent data, actually, that was preclinically summarized here, but clinically presented by, in fact, the Mount Sinai group by Achai Chari at ASH, in which Achai showed really nicely not only a favorable tolerability profile, but a response rate of around 70%, including some very high-quality responses. So this was a true first-in-class off-the-shelf therapy targeting GPRC5D with ongoing expansions ongoing. And it's great to have Donna as part of the panel today because I know she was involved in this study. So in terms of BCMA targeted immunotherapy, I've just sought to sort of summarize it here by showing you that we've got obviously the CARs, we've got the bispecifics and the BiTEs, but at the same time, we also have the antibody drug conjugates. And you'll hear much more about this from Rafat in just a moment. But this is obviously a truly off-the-shelf approach in which we combine the BCMA targeting with the chemotherapeutic, methadone in this case, and the results have been quite remarkable. But I think what's particularly interesting is when this was combined with other therapies, such as pomalidomide, most recently at ASH, the data from Dr. Suzanne Trudel were extraordinary. And I know Rafat is going to come to that in a moment. You can see here how immunotherapy combined with other strategies is doing remarkable things. And this really brings me on to my next point, that as we think about BiTEs and CAR-Ts, we will probably be bringing some of these new maintenance strategies, such as building on the IMID platform, into this space. What I mean by that is that these may be drugs that we add to the CARs, add to the BiTEs going forward. And probably the best or best candidate in this respect is iberdomide. This is CC220, as it's called. It's in the CELMoD class. And this may be an ideal platform that will follow CAR-Ts and BiTEs in the future as a cellular therapy maintenance strategy, in my view. The reason I say that is because obviously all our patients will have had immunomodulatory drugs such as lenalidomide and pomalidomide early. And so after these immunotherapeutic approaches, strategies aimed at targeting to maintain the immune response may include agents such as iberdomide. Now, the big question about these CELMoDs is, in fact, can they do it even on their own? I mean, do they need, in every case, a CAR-T or something innovative like that up front? Well, clearly, our data to date would say no, that in fact, these CELMoDs have really been a next step up. This is data from our own study. This is the 92480 platform. And just to give you some background as to what these CELMoDs do, they are so-called E3 ligase modulators. And they're in a different fact. They're related to the IMiDs, but they're different. They're that much further distant in terms of their pharmacology and their construct, but their effects are dramatic on the cereblon E3 ligase complex with this extraordinarily powerful targeting of ALOS and Icaros, which in turn not only has tumoricidal effects, but critically profound immunostimulatory effects that are way beyond what we've hitherto seen. And as a result of that, we've been very pleased to see, and this is just from single agent 480, 55% of our patients in this phase 2, or rather RP2D dose cohort, recognizing the number here is relatively small, but the signal is nonetheless very strong, that just with 480 plus dexamethasone in these highly refractory patients, we saw a 55% response rate. Now, important to remember, this is just a pill, taken 3 weeks on, 1 week off, and the steroids administered weekly. So this is a highly convenient approach for going into a whole new area in terms of response. Now, these patients, the 55% responding patients, were refractory to everything that was available up to that point. They were triple-class refractory, and so therefore constituted an exquisitely vulnerable population. So we're very excited by that. This is one of the patients in this particular study. I'm very grateful to Dr. Nizar Balis for sharing this particular PET CT, but this patient in particular had extramedullary disease in their liver, which is obviously a very ominous finding. And as you can see, with 480, cycle 3, day 1, this large mass had completely disappeared. This is just a pill, and exploiting the immune system to so do. So really a very, very exciting approach, which we think is particularly promising. So I just wanted to close with these summary points and just perhaps some future directions. Obviously, as we think about the relapsed refractory space, and we're going to hear beautifully in a minute from Rafat about the various options that we have, whilst we fully recognize that triplet therapy is the gold standard at the moment, to which things can be added, we're very hopeful that this new wave of immune therapies, in particular targeting BCMA, be it the antibody drug conjugates or the CAR-Ts to come hopefully very soon with the approval at the end of this month, and then perhaps the real impact of the so-called bispecific T-cell engager therapies can really take our treatments up to a new level for our patients. And by that same token, will the cell mods provide us with that same next big push? And so I'd like to close by saying, as we think about this and move these strategies earlier, will we be in a position to offer patients earlier in the course of their disease truly immune-targeted approaches that generate durable responses that continue for many, many, many years, and provide patients even with the opportunity for treatment-free periods where the immune system has done such a good job that essentially they can be off therapy and then enjoyed a true treatment-free period. And you might say, does that mean functional cure? I think that that's a possibility indeed. I'm very cautious about using that term because myeloma over so many years of caring for my patients, it always humbles me. But at the end of the day, I do think this is one of the most exciting and promising horizons for all of us as we look into 2021. I want to thank you very much for your kind attention. And obviously, Brian, open for any questions. Thank you.
Thank you so much, Paul, for this comprehensive overview of the immune therapies, especially the CAR-T and then the bispecifics. Very, very exciting. And we have questions coming in here already. But what we're going to go do is we're going to go ahead with Rafat, focusing on specific approaches to the relapse setting and where do all the different options fit in, and then go forward from there. So thank you so much, Paul, for that stimulating send-off with the immune therapy strategy. So, Rafat, glad to welcome you from your center in Indiana University, Indianapolis, and you're going to take the confusion out of what to do next. So, go ahead, Rafat.
Well, yeah, good morning. Thank you, Brian, for inviting me to participate in this meeting. I wish we were in Boca Raton, but here we are.
Yeah.
And Paul did an excellent job, really, tell us about immunotherapy and the excitement of that. So my job is to sort of talk about, how do we approach relapse disease? Okay, I'm going to ask the audience, maybe they can put in the chat their response. What do you call the second COVID vaccine? And I'll come back to it at the end of the talk. So when should we treat patients, with relapse disease? Do we treat them when we have a biochemical relapse? That means the myeloma proteins start going up, the free light chain that is involved going up? or when they have a clinical relapse, the CRAB criteria, anemia, kidney failure, high calcium, or new bone disease? Do we treat them when they have extramedullary disease, like the patient Paul just showed you with a mass in the liver, or if they have plasma cell leukemia? The answer is we really don't know yet. We can speculate. But I just want to bring to your attention that most approved treatment today in relapse multiple myeloma were based on biochemical relapse, not symptomatic relapse. But there are two observations support better outcome when you treat at biochemical relapse. One from Mayo Clinic, when they looked at the patient treated at biochemical relapse versus symptomatic relapse, and there was a significant difference in median overall survival, 125 months versus 81 months. There was another trial called the Endeavor trial, showed similar results. So what are the cons and pros of treating at biochemical relapse? Well, about 25% of biochemical relapse, when just the myeloma protein is going up, may actually have a smoldering course with no progression for over 2 years. So maybe these people get overtreated. The pros is that some observations showed that median time between biochemical relapse and clinical symptoms, maybe it's about 6 months. So why wait until you have a broken bone, renal failure to treat the patient? Similarly, what we're doing with smoldering disease, but it's a little different. And the other pros is that if you really don't get it right at the first relapse, you may not get it right at subsequent relapses. Why is that? If you look at the duration of response with each relapse, for example, with first relapse, the duration of response could be about 10 months. With second relapse is shorter, third relapse is shorter. So with each relapse, the duration and the depth of response is shorter. So I think we need to get it right at the first relapse. I think it's very important. And you heard from Paul about the genomic heterogeneity that's affecting the course of multiple myeloma. So because multiple myeloma patients have distinct subclones, smaller population of plasma cells that are sort of causing intramural heterogeneity, affect the course of the disease, and affect the outcome with each relapse. So to say that in English, what is clonal heterogeneity is that myeloma cells in each patient are a family of odds and aggressive members. The longer this family stick around, the odder and more aggressive it becomes. So family therapy is not going to work. You cannot be politically correct here. You have to eradicate them quickly. This is making a case for early treatment with combination therapy, as you heard from Paul and others. We're not going to win with single agent drug or 2 drugs. We need combination therapy to address the clonal heterogeneity and prevent these cells from becoming aggressive and then causing relapse with extramedullary disease, plasma cell leukemia, and the like. So what are the factors that influence the choice of therapy at relapse? They are disease-related, regimen-related, patient-related. So what are the disease-related factors? What is the clinical feature associated with relapse? Symptomatic disease, extramedullary disease with hyperviscosity, came from high-risk cytogenetic, you have extramedullary disease or high-risk myeloma. That will influence your combinations and how you do decide on the appropriate treatment. The regimen-related factor, what was the previous treatment and the doses the patient received, the duration of prior response is very important. The side effect of prior treatments, prior drugs and combination is very important. You're not going to repeat drug that caused significant nerve damage or caused significant allergic reactions or the like. And the depth of and duration of prior treatment or previous transplant also can influence what we do. Do we do a second salvage transplant 5 years later? Maybe. And obviously, we need to respect the patient's related factors, how they feel, what's their performance status, do they have any other medical issues, are they eligible for transplant or not, what does the patient want? And, obviously, sometimes we have to address cost and socioeconomics. So this is a list of currently available anti-myeloma agents. As you can see, there are a lot. Obviously, we still have the prednisone and the dexamethasone. We have these conventional chemotherapy with novel twists on them, such as the newly approved melphalan. We have the IMiDs, thalidomide, lenalidomide, pomalidomide, the Revlimid, Panelists. We have the 3-proteasome inhibitor. We have the HDAC inhibitor. We have these immunologic-based approach, and then we have the EXPO inhibitor, selinexor. So how do we choose, Basically, how does your oncologist decide? It's like you're going to this restaurant with this incredible menu, It's very difficult. I mean, which salad, which, main I want to choose from? Well, it's actually, this is what your oncologist is seeing. I mean, every oncologist is following what we call the NCCN guideline, the National Cancer Center Network guidelines. And look at these regimens. It's great that we have options. Look how many options available for relapse patients. But the bad news is that your doctor may get confused. Which one I'm going to pick from these combinations? Well, I mean, you could probably use your Mayo practical approach to first relapse. For example, if they were on maintenance Revlimid and they relapse and they fit, you can, for example, use carfilzomib, pomalidomide, and dexamethasone, or Dara-VD. So this is an attempt, by our colleagues at Mayo Clinic to sort of make it easier for the oncologist compared to the NCCN guideline. If you have somebody who, for example, relapsed and was refractory to lenalidomide, you will probably use something different. So these are available, and I'm not going to spend a lot of time on it. Obviously, if somebody has a very aggressive relapse, so is extramedullary disease, if there's no clinical trial available to them, we may be very aggressive, use this combination chemotherapy in the hospital for 4 days, a month, for 2 months, and then maintain him after that. So, so let's spend, a few minutes talking about some of these combinations. So you heard again, it's really not good idea when somebody relapses to just use a single agent drugs, because single agent drugs, most of the, they're going to give you a 33% response rate. So, and these, for example, drugs, when approved in combinations with based on clinical trial, showing that 3 drugs are better than 2 drugs. For example, in this trial, in the old days when somebody relapsed, we're going to give them Revlimid Dex. How about adding a monoclonal antibody to daratumumab, anti-CD38? And what you can see here is that in this trial, the time without relapse is much longer with 3 drugs, and the median not reached. However, when you just use Revlimid Dex, patients start relapsing or having symptoms related to the disease within 17.5 months. So clearly, 58% is better than 35%. So 3 drugs better than 2 drugs. Combination therapy is very important. And, the response is deeper. You're getting more patient getting complete remission, stringent complete remission. And that is translating to a better survival. Patients stay alive and staying without disease much longer. And the other thing is that combination therapy is leading to a deeper level of response. You're getting more patients achieving minimal residual disease with the 3-drug regimen, as you can see here, based on different sensitivity of the assay. But clearly, in a very sensitive assay of, let's say, 1 in 100,000 cells, you're not finding a single myeloma. There are 27% of the patient achieving that versus with Revlimid Dex is only 5%. So clearly, the quality of the response is much better when you get a minimal residual disease. And patients who get minimal residual disease enjoy a much longer survival without symptoms related to the disease. And in this analysis, basically, time from last line of therapy to study treatment, again, if patient got a late relapse or early relapse, combination therapy is superior. And so, again, makes the case that when you have a relapse, you need to use combination therapy. The Castor study is similar to this study, but it was comparing daratumumab with bortezomib dexamethasone to salvage with bortezomib dexamethasone. And similar observation was noted here, and the depth of response, the quality of response were similar. And again, whether you're using it for early relapse or late relapse, still there's benefit to combination therapy over just the doublet. So these two studies are seminal studies showing that combination therapy is very important at relapse, and overall survival is in favor of combination therapy. So the other really advanced in myeloma therapy came last year when the FDA approved drug belantamab mafodotin. And this is really an exciting advances. So this is, you heard about the importance of BCMA as a target for immunotherapy. Everybody is using BCMA, whether it's a CAR T cells bispecific. But the only approved anti-BCMA drug right now is this drug. And it works in two ways. It's an antibody, so bind to the myeloma cells and then bring the immune system and help eradicate the myeloma cells, but also has a conjugate added to it. And this conjugate, it's a tubulin sort of inhibitor, we call it. And basically, it goes inside the cells, this cytotoxic agents, and then blow up the cells. So it has dual mechanism of action. One is bringing the immune system to try to eradicate the myeloma cells, and then getting this cytotoxic agent, MMAF, within the cells to help eradicate the myeloma. So what happened, I think this is just one of the many trials have been presented with this drug. And this is the sort of phase 1 study showing that there are a lot of patients had a response with an overall response rate initially of 60%. So what you heard from Paul is that we are building on these agents because, again, all drugs have to be first approved as a single agent to show activity. And then the next thing is that you use it in combination. So there are a lot of combination using this drug, ongoing in clinical trials showing efficacy. And I think eventually this drug will be approved in combination and probably different dose schedule. So you heard about the major issue related to this drug is really the ocular toxicity. And the mechanism why patients are getting eye symptoms related to this drug is not very clear. But mostly is corneal, the cornea damage related to this treatment. And so it's very important that this drug is not giving until you have a good eye exam. And prior to each cycles, you should be having an eye exam. And I think, nowadays, I think we've been able to find ophthalmologists and optometrists in our network that can really provide us the exam quickly and provide us the results. Because you heard earlier in the morning that you need to know if the patient is a go or not in terms of getting the treatment or not, because if there's significant toxicity, you need to hold the drug until the symptoms resolve, and then you can restart it. And it's one of the things that the patient can do is to use non-preservative eye drops, like artificial tears without preservative frequently to keep the cornea moist and prevent it from getting ulceration. The other recently approved drug, and Paul can probably provide you with more data on that since he was the PI on this study, is really this new drugs, melphalan, in patients who have been relapsed to many line of therapy, including daratumumab and pomalidomide. So what is this drug? It's an interesting drug that has several mechanisms of actions. I'm not going to go through them, but it really, you know, it's an easy sort of modified alkylating agents that can be given once every 4 weeks and lead to significant myeloma destruction. And in this study, the primary endpoint was obviously overall response rate for the single agent drugs. And these are the patients, you know, you can see that in your handout. But all I want to tell you is that there's significant response with single agent activity. And some of these responses were quite deep, complete remission and stringent complete remission. So again, it's a new drug that is available to us to help us, compact multiple myeloma. Because of time restraint, I haven't been able to go over the list of all the medications I've showed you earlier. But I think, you know, the best therapy for relapse, that we need to know that not all relapses are the same. So, and the good news is that we have options that will suit each patient we treat. We know that combination therapy provide better outcomes, so we should be adopting that to all of our patients. And, you know, we have amazing, options today, which is really, great. 20 years ago, we had, 1 or 2 drugs. Now we have many drugs and many combinations. So really the optimal therapy is the one based on your needs. And I really cannot underscore the need to get it right at first relapse, because if we don't, the disease become more aggressive and very hard to control. With that, I am done. Thank you.
Okay, well, there you go. There's a poster for relapse and myeloma. So thank you so much, Rafat, for that excellent overview of how to approach relapse, and then some of the more important newer agents for treatment in relapse. And there are questions in here, and I'm tracking them. But first of all, we will go forward and hear from our final speaker of the morning, patient advocate extraordinaire, and he will be focusing on something which is tremendously important. Is, yes, you want to be in remission, but you want to maximize the quality of life along the way, which is what it's all about. So welcome, Yelak. As always, we look forward to your lively presentation.
Thank you, Dr. Durie. This particular slide is a reminder that March is Myeloma Action Month, and if you go to the mam.myeloma.org website, you will see a lot of actions you can take on a daily basis to increase your quality of life while living with multiple myeloma. Thank you to all the doctors and Donna for the excellent presentation. If we were in Boca in person, I would have asked the audience to clap for you. So we'll plan to do that next year. My presentation is going to be less technical and touch the softer side of living with myeloma and treatment for myeloma. This past Christmas was my 25th Christmas since my myeloma diagnosis. For me, Christmas is always bittersweet. It was right after Christmas in 1995 when I was told I have myeloma and I was given 2 to 3 years to live. At that time, I was 25 years old. I was recently married. I just finished my undergraduate school and had started going to graduate school and studying computer science. And the diagnosis of myeloma did change mine and my family's life trajectory. I vividly remember my first day of chemo. This was pre-novel therapies, and it was a real chemo, vincristine, adriamycin, and dex at that time. And all my immediate family, including my parents who were visiting at that time, were crammed in a small chemo room at Medical City in Dallas. I actually remember the room 272. Everyone was waiting for me to start throwing up immediately and lose my hair right there and then. We have watched too much TV leading to my first chemotherapy. The anti-nausea medicines worked for me. I don't remember throwing up through my treatment, but I did lose my hair. This one actually is natural, but at that time I did lose my hair because of the chemotherapy. And the 4 days on and 4 days off, if you remember, of steroids, and extended period in front of the fridge gave me at that time the moon-faced chemo phase. But I tolerated the medicines well, except fatigue, which seems to get worse from treatment to treatment. And I was able to carry my 4 days infusion of VAD and saline to class and sit at the back of my class and not miss any class and graduate on schedule. At the end of the 6 months of high-dose chemo cocktail at that time, I achieved stringent complete remission. I opted out of doing an autologous stem cell transplant and collected my stem cells, which were frozen and stored for possible future use. I know I'm lucky to continue to do well and live well with myeloma and not for myeloma now going 26 years. I'm thankful to my family, my friends, and the novel treatments that came along, and my exceptional doctors, nurses, extended care team who cared for me and continue to care for me. But I'm most thankful for and recognize me standing on the shoulders of my fellow myeloma patients and other advocates who came before me and chose to bravely light the way ahead of me. So what I plan to do in 10 minutes or so is share the hope and some tips and tricks that worked for me for the last 25 years. Like most of you, I'd rather live without cancer. I'd rather live without myeloma. But if one has to be diagnosed with myeloma, I think this is the best time of all. There are unprecedented amounts of options. There are new drugs or combination of drugs that seem to come up frequently compared to other cancers. And for me, having myeloma had enabled me to have relationships I would not have imagined with patients, with doctors, with other caregivers. It has forced me to also become a lifelong learner. Things change on a regular basis for myeloma, and it really is important to keep up. My story, like most of you's, has the beginning, the middle, and of course the end, which I hope is far down the line. The beginning is, when I was diagnosed, what my symptoms were, what type of myeloma I had, what are the risk factors I had. And the middle is really interesting and more complex and different for each one of us. What are the types of treatments that I took? For me, immunomodulators, the proteasome inhibitors, the molecular antibodies, and radiation treatment, the side effects, neutropenia, neuropathy, diarrhea, and the tests I took along the way. I actually will go to this slide. And one of the questions I get asked is how many relapses I had, or how many, if this is my first relapse. If I'm counting, this is actually, I have had 5 relapses and remissions, but I have stopped looking at my myeloma survival in increments of reaching remission or relapse. I really want to measure how I am living with myeloma versus for myeloma. Because one thing I want to make sure is that I'm not forgetting to live while I'm fighting not to die. I think that is really important. And this slide shows there were a time that I was on treatment or on maintenance. There were times where I was treatment-free and maintenance-free. There was times where I was on maintenance, soft maintenance, and 18 months later relapsed, and my myeloma progressed, and I got back on treatment, went back to stability, and so on, right? But one thing I want to highlight here, and I think as patients we need to have a conversation with our myeloma specialists, is I'm a proponent of having a leading indicator of my myeloma to show if a treatment is working or if progression is starting, and being able to act accordingly. For me, the free light chain test and the PET CTs have been a great leading indicators of how my myeloma is responding and how the outcomes are coming out. One thing I want to mention is that it is critical that to know as myeloma patients, myeloma is not our fault. We don't know why we got myeloma. But no, we are not alone. There will be over 32,000 people in the US that will get myeloma this year. 88 people were told they had myeloma yesterday. In each and every day, 88 people will be told that they have myeloma and their lives will be changing forever. What we are attempting to do is not live forever as myeloma patients, right? Because each and every one of us at some point will end up dying. Our goal as myeloma patients is to be able to maximize how long we live with myeloma, while also maximizing our individually defined quality of life. Because my definition of quality of life is different than somebody else's definition of quality of life. One of the common feelings we all encounter when we are initially told we have myeloma or when we have our first relapse or progression is fear. Fear of dying and leaving someone we love behind, fear of the unknown, fear of what is to come, fear of the disease side effects, fear of the treatment side effects. The question I want us all to ask is, would our relationships with our loved ones, would our relationships with the ones who care, our responses, our actions towards cancer, our relationships with God or whoever we end up living in, be any different if we actually conquered fear? What is it that we need to do so we don't forget to live while doing that, what we can to avoid dying of myeloma, right? That is really the one of the most important questions that we ask. And the physical aspect of it and the discussion that we have had today is important, but so is, in my opinion, the emotional and the mental and the spiritual aspect of it. To me, it is a triangle. You cannot have one without the other two, and being able to do that, right? You don't have to be spiritual or take care of your emotional being by yourself. It's okay to ask for help, enlist the help of a therapist or a spiritual leader. You can't fight all the battles that come your way. You should choose to fight the right battles for you. For example, you may feel tired. Rather than trying to power through it and feeling miserable, can you take a 15-minute break or nap and then power through it? One of the most important lessons for me in living with myeloma is the relationship I build, the relationship you build in myeloma world, sometimes determine the outcome you are going to have. The relationships with your caregiver, the relationships with your myeloma specialist, and the relationships with other patients. But the most important one, in my opinion, is developing the knowledge required to be a good patient. It could be you, it could be your spouse or your caregiver, or it could be your kids or somebody in your extended family. You need to educate yourself about what is myeloma, what is the quality of life you want, what are your options, and on and on and on. So I will build this slide, and you guys should have this slide available. If your situation allows, one of the best advice I can give you is to ensure the best outcome, you need a myeloma specialist. Over time, you need to know your myeloma defining events. And if we have time for Q&A, I would like to ask you to ask the myeloma specialist, what is a myeloma defining event and how do I find out that for myself? As you'll find out, as you live longer and longer with myeloma, living with myeloma, in my opinion, is about finding the right balance, the balance between treatment and outcome, balance between outcome and side effect, balance between when to complain and tough it out, balance between drug effectiveness and drug affordability, and balance between the short term and the long term. So this concept of balance is really important, but so is the treatment team that you end up building. This is a slide that shows some of the key specialists that need to be part of your care team. One of the most difficult things to do, but it needs to be done and consciously be decided, is who is going to coordinate care in this specialty. Your caregiver is a really integral part of your survival team. It is important to have an open discussion with your caregiver of your what help you as a patient do you need, and are you able to receive as a patient? How much help is your caregiver able to give? What will you do during hospitalization? How do you avoid your caregiver, or how does your caregiver avoid you during the days of DEX treatment, right? But we also talked about your myeloma expert is one of, if not the most important part of your care team. You need to decide, though, what are the characteristics of a specialist you want, right? We have here 3 myeloma specialists behind that are answering questions. How do you choose between them? That is really a personal decision that you really need to make, and is important in building the relationship with the myeloma specialist that you want to continue to have that relationship. As I mentioned earlier, living with myeloma is a balancing act. Some of the questions I ask when considering a new treatment are, will I live longer if I take this treatment? Will I have a better quality of life if I am taking this treatment? How can my myeloma specialist help me personalize the treatment and the treatment outcomes, and do, based on my risk factors, if I take this treatment or combination of treatments, will I relapse early, or would I relapse late, or is my relapse standard? Can I have that conversation with my doctor even during this pandemic is really important. And one of the things I think that we need to decide as a care team is, taking this treatment, will it prevent me from having future treatments, or close the door for me from having future treatments? And remember, your doctor is your advisor. Your doctor knows about the science of your treatment, but you know what your personal situations are, how to articulate and communicate and maximize your quality of life. And in my opinion, at the end, you make the decision based on many things with a strong advice from your myeloma specialist. As I mentioned earlier, living with myeloma requires achieving a fine balance between outcomes and side effects and quality of life, between treatment for now versus anticipating the future of both your personal outcome and what is in the pipeline, and making sure that you are not closing the door for future treatments. And also, I think it doesn't get talked a lot about in these medical meetings, but the cost and the value of treatment, right, is being able to balance that is important. I think what I want to leave you with is, as we wrap up, is as a myeloma patients, we don't get to ring the proverbial done treatment bell. I have seen many patients ring the bell in my cancer center. They finish their treatment and exit the door, hopefully for them for the last time. We don't get to do that, at least not yet. But we need to learn to take the victory laps, as my cats used to say. We need to celebrate each and every win, each and every progress. If you can take only one message from today's talk, take this. While avoiding to die, don't forget to live. While avoiding to die, don't forget to live. Thank you, Dr. Durie.
For you, yes. Great presentation, as always, Yelak, and really reminding people to focus on the living part of the ongoing therapy and have the quality of life that you deserve. So we do have time for questions, and just as people can maybe see, so far there have been 368 questions, and so we're not going to be able to cover those. And so please forgive me. Amira, just keep them where they are. Yeah. So please forgive me. I'm going to pick up on some that I've been noting down that are, I think, maybe the most interesting. And maybe we'll work backwards for our last three speakers. So Yelak, one, I think, interesting question for you related to quality of life was, how have you balanced taking maintenance therapy related to the side effects? And then the questioner also asks related to the possibility of increased risk of a second cancer if you're taking maintenance. Do you want to comment on that, perhaps?
Sure. I'm really good at quote-unquote complaining and letting my doctors know what the side effects of my maintenance therapy are. And fortunately for me, my doctors have been really responsive about managing that, either through decreasing the frequency with which I take a treatment, or in some cases completely discontinuing, but watching me closely. So in my opinion, that open conversation and your doctor relationship is really important in making sure that they understand what the side effects are and help you manage them. One thing I advise against is self-managing side effects and skipping treatment or decreasing how much DEX you end up taking. Be transparent with your doctor and allow them to help you manage the side effects.
Okay, very, very good advice. Yeah, I think that, you do need to disclose if you're taking extra vitamins or different things that maybe could even be interfering with your treatment, for example. So let's go to the immune therapies. One element that's come up in the different questions related to the immune therapies, Paul and Rafat, is, and you touched on this, Paul, when you mentioned maybe functional cure with CAR T therapies. An important difference in the immune therapies is that with CAR T therapies, you have this single therapy, and then responding patients, for example, can be in remission for a year, 2 years, even beyond that. And so then they have this time off therapy, which may be the first time in years that they've been off therapy and in remission and having excellent quality of life, versus belantamab or the bispecifics, where those treatments are ongoing. So maybe, Paul, maybe you could start and comment about this aspect of these therapies. Paul, yeah, we need your audio.
Yeah. Can't hear you.
I apologize. Can you hear me now, Brian?
Yes. So I'm sure
Perfect.
that you have a number of patients who've been in remission for some time with CAR T, for example.
Well, to be honest with you, I think we have to be careful here, because I think that the median duration of response from the KarMMa trial, for example, was about 11 months. So I think we just need to be very realistic. I think you're absolutely right. The promise of an approach that allows a treatment-free period is encouraging, but I do think we need to be thoughtful about the fact that the degree of disease control, on average, the median, is 11 months. So a good start, but a ways to go. And I think that, to Yelak's point.
I was giving the median for the patients who have CR or better, which was from the New England Journal paper, for the deep responders.
Right, and I agree, Brian. I just think we just have to be, for our audience, just very realistic, that in some patients we see tremendous results, and in others, it's more challenging. So I think you're absolutely right. There's the promise of treatment-free period. I think the other way to think about it is, are there strategies that could be added to CAR T to enhance the durability of response for everyone, with, again, minimal side effects? And I think Yelak was touching on that. If we can improve on oral therapies that are well tolerated to enhance the response, that would be great. I think, though, the promise of the immune therapies is that they could achieve high-quality remissions that we currently achieve with other strategies, but do so with a better long-term outcome. And in that regard, for example, the use of high-dose melphalan, a great old warhorse and very helpful for us. I'm going to say old, I use that term carefully, but it's an older warhorse. The hope is that, with these newer therapies, they could potentially even replace high-dose melphalan as we go forward.
Right. So Rafat, what's your perspective on these immune therapies? The possibility of treatment fee interval versus ongoing therapy with many of the therapies.
Yeah, I think what we really need to, take a moment to cherish immunotherapy, CAR T cells, because it's incredible. You're taking patient T cells, you genetically modify them, you make them myeloma killer cells. You're taking a patient who had multiply treated with horrible myeloma, and you're getting MRD negative within a month. It's incredible. It's just amazing. So I'm really excited about CAR T cells. And I think it reminds me with early model CARs. They weren't the perfect CARs. But I think, there is a tremendous interest in this technology. And I think what will happen also is that a lot of people are trying to use, T cells from donors and, and genetically modify them so they don't react with the patient's other organs, just kill the myeloma cells. So there will be a source available to use, again and again. So I think this is amazing. And myeloma is a tricky disease. I think what we really need to understand is what is the sort of the residual disease that we cannot detect, with our current technology, and how can we get rid of that? Also, now there's a lot of emphasis on immune profiling of patients after therapy to see what is the appropriate immune profile to keep the disease from coming back. That is also exciting, and some of the drugs that mentioned by Paul may be, the answer to that. So this is an exciting time, to see such a response. So I'm not worried about the duration of response. I think we're going to get better.
Yes, especially if we use it earlier and earlier, like in the KarMMa-4 trial, or where there could be a greater benefit with earlier use. There is a sort of a related question earlier on where, the first question is a gentleman who's in his 70s is saying how about these new therapies? I think concerned about the cytokine release syndrome and the like. Are these therapies okay for someone who is more in their 70s or older? What about that?
Yeah, I think that's a great question, Brian. And I think we have to be careful. I don't know if you can hear me. I hope so. Yeah, thank you.
Yes,
I think we have to be a little careful. I think that the younger patients undergoing CAR T therapy and tolerance of CRS, obviously, and if they're otherwise very well, has been good. But I think the question is absolutely right, that as we move these technologies earlier, we also need to be very aware of real-world practice. And I think, again, I agree with Rafat 100%. The promise and the potential is very real. I think we just have to be, in fairness to our patients, very realistic that there may be certain patients who will really benefit, but we have to keep a beady eye on strategies for other patients, such as those in their late 70s and so on, who may benefit from a very different strategy, but built on the same principles, that we have immune treatments that can be delivered to them in some form or another without necessarily the potential risks of CRS and so on. CRS is very important in patients. It's important to remember that endothelial damage in myeloma is a major concern. It's a concern because it's why our patients are vulnerable to blood clots. Underlying vascular damage is important to some of the cardiac toxicity. Vascular injury broadly is an area that we need to be very thoughtful about, because it also is relevant. Actually, it's also relevant to COVID-19. That's another point to bear in mind.
Could become quite important related to that, an ongoing concern. So another question, I think this is mostly for you, Rafat, is you mentioned different ways of looking to select best therapy for a patient who's relapsed. This patient is wondering, is there a particular battery of tests that you get in a relapse patient that would guide your choice? I think they're thinking particularly about maybe repeating the FISH testing or what tests, if any, do you rely on to guide your choice of relapse therapy?
Yeah, I think we are all looking for that day when we can do a genetic-based testing to choose the appropriate treatment for a patient. Nowadays, I don't think we really have a great targeted therapy, except, obviously we don't have an approved drug, but for example, patient with translocation 1114 with BCL2 overexpression may benefit from drug called venetoclax in addition to proteasome inhibitor. So the combination of venetoclax with Velcade or Kyprolis may be beneficial. But that's the only available, sort of targeted therapy based on genetic information we are gaining. Right. Obviously, if I have a patient with high-risk cytogenetic, I'm going to try to be more, aggressive in a combination I use, especially when they present with an aggressive relapse, extramedullary disease or the like.
Right, exactly. Okay, so another broad question, and maybe Paul, you can start first with this one, is if a patient has achieved MRD negative at 10 to the minus 5, does such a patient really need to go ahead with a stem cell transplant or other aggressive therapy, or maybe just stick with go on to maintenance? So this is like the $64,000 question, maybe, but yeah. What do you think about that one?
Well, it's a super question, and I think it points to the real excitement in the sense that our current platform of drugs is able to achieve MRD negativity, giving us the choices that we can really tailor therapy. So I think if someone achieves the functional equivalent of MRD negativity, be it stringent CR or MRD negativity by actual testing, recognizing that's not always available to everyone, the ability to then tailor treatment to being less intensive, and also, very importantly, maintaining that remission, but doing so appropriately with immunomodulatory treatment like lenalidomide being a standard. Personally, I'm very comfortable using proteasome inhibition as part of that, together with the knowledge that there's data to clearly support using an augmented maintenance approach, particularly in higher risk patients. But if, for example, I collect stem cells and don't go to transplantation, I'm very comfortable continuing both lenalidomide and bortezomib for a patient, provided they're tolerating it. And there are various strategies to maximize that. So I agree with you, Brian. I think it's very appropriate to keep, or to think of keeping transplant in reserve for patients in whom that could be safely done, recognizing we now have long-term data from our French partners where doing transplant later had no impact on overall survival. The outcomes were identical. And what was also very important from the French follow-up was that with a median follow-up of 8 years, there was no difference in the outcome between the two groups, either doing transplant late or early. So that gives us the real option to keep transplants in reserve.
So there's actually a related question, which is quite interesting. A gentleman is asking here, has been taking Revlimid and Ninlaro since 2017, doing very nicely low-level disease, wanting to know whether you should continue with that.
I mean, Rafat, I love your comments. I personally have a lovely old saying, if it isn't broken, don't fix it. I mean, or if don't mess with success is probably the better term. I would simply say if he's tolerating it well, I would be very much in favor of that. And again, the issue of long-term side effects is something we're always on the lookout for. As best as we can tell, there are no long-term side effects from ixazomib. Lenalidomide, Yelak touched on before, there is an association with second cancers, but it's particularly magnified if you've had melphalan. If you haven't had melphalan, the same signal from lenalidomide isn't nearly so big. So for that big I want to be very careful about, because the relative risk is quite low. So I want to be very cautious in that statement. But lenalidomide, ixazomib, in terms of second cancer risk is very low, to the best of my knowledge.
Right. Very good. So Rafat, do you just keep people on maintenance if they're doing well and tolerating the therapy? Or do you have
yes, I think the most important thing is always, weigh risk and benefit, and
Right.
pay attention to the side effect, fatigue, severe anemia, cytopenia, adjustment of the dosing. I think is very important. A little treatment holiday may sometimes help. But it's really, as Yelak said, I think the most important thing is that do not be shy about your symptoms, because today
Right.
we have options, and great that we have options for you, because, symptoms are not a badge of honor. You have to live your life, and, you not need to be next to the bathroom all day long because you have a horrible diarrhea or having significant neuropathy, you cannot sleep. Talk about your symptoms, because we can adjust the treatment.
Yeah, absolutely. Absolutely. So we're almost to the end of our time here. There's one last question on COVID-19. I have to say, there are just so many questions about COVID-19. I had mentioned earlier that it was not a good idea to take Darzalex IV on the same day as the vaccination. And then so someone asks, well, how about if you take the Darzalex sub-Q, the Fast Pro, and you got vaccinated with the Pfizer 4 days later? Is that okay? I think that we just, there's so little data for us to try to help with that. But anyone want to comment on that? I would say that should be fine.
Well, it's very interesting, Brian. Our own policy has been to avoid steroids with our vaccinations. So avoiding steroids with vaccinations is I think, number one. The other tangential data we have is that receiving conventional chemotherapy, that's cyclophosphamide or similar, that in flu vaccinations, in the setting of flu vaccination, was counterproductive. So if you can avoid steroids, avoid chemotherapy, I think that makes sense. I agree with you, Brian. The picture with an antibody is much less clear, and certainly proteasome inhibition, IMiDs, the same. We actually do have data that taking IMiDs can enhance responses to vaccine. My colleague Nikhil Munshi ran a very nice study in smoldering myeloma, showing that you can enhance responses to vaccines by using IMiDs. So interestingly, I think those factors can be borne in mind.
Yeah. A lot of important nuances here. So thank you very much. Well, I think we're at the end of our time here, and I think that a very great thanks to all of our speakers today. I think that great presentations, a lot of good questions, and sorry that we haven't been able to cover all of them. We're now up to close to 400 questions, so it's a lot. There is a webinar survey. I think that as we start our virtual series for 2021, we're very interested to hear your feedback as we try to tweak and improve these types of interactions and look at different platforms potentially. And so we're very interested to hear your feedback about how this has worked for you, and we'll appreciate your feedback. And so with that, I'll proceed to close. I think we obviously yet again would like to thank our sponsors who make these things possible, and very grateful to them. And so with that, I will wish everyone a great weekend, and we are starting to see the light at the end of the tunnel, and we really appreciate that things will hopefully be getting better for all of us. And as you've heard today, despite everything, myeloma research has been incredible, and we have so many options available to improve chances of remission and long survival. So thanks to everyone.
Thank you.
Great.
Thank you all. It's nice to see you all too.
Yes. Susie is saying bye as well. Thank you so much.
Great.
Thank you, Yelak.